given the topics regarding about pressure management and overview. And then actually this is part of my dissertations as well during my master's program in this wound healing and tissue repair at Cardiff University. So it is actually part of the very important issues, I think, nowadays in the months of November, which everyone in the global world is talking about stop pressure ulcers. I think it's always challenging for us to understand about the etiologies, the pathophysiology, or even the mechanisms of the pressure injury itself. So yes, so basically my information that I'm going to share with you are from this international guideline, which is actually the published in 2019. Okay, as a definitions of the pressure injury, as a clinical definition, it says that the localized damage to the skin and or underlying tissue as a result of pressure or pressure in combination with shear. And the pressure injury usually occurs over a bony prominence, but may also be related to a medical device or other object. I think this kind of definition in the 2019 guideline is slightly a bit lengthy, because in the 2014, I think it's actually talking about over the bony prominence, but these definitions here in the 2019, actually it extended to the medical devices that related, the causes of the pressure injury on the body itself. So I think there's some more information that we can share, we can understand and have a better understanding of how the pressure injury has been developed, in our clinical works itself. So basically, it talks about the factors influencing the susceptibilities and then developing of this pressure injury. Basically, this is the risk factors that was actually been highlighted in the international guideline, which was actually been published and studied by Professor Kuhlmann and published in 2013 and 2014. However, in the 2019 international guideline, they are still continuing using these risk factors. I think it is very, very relevant. People understanding about risk factors like systemic risk factors, all the local risk factors. But however, by these study guidelines here, it actually can be divided into a mechanical boundary conditions and the susceptibility and tolerance of the individual. So what is it all about is that mechanical boundary condition is talk about the magnitude of the mechanical load and time durations of the mechanical load and the type of loading, which is a shear, pressure, and also the frictions. So this is actually the pressure, the load that was actually exerted on the tissue. It can be from our bone, it can be the bone that was actually accumulated all the forces into the bony prominence, and then that bony prominence was actually exerted on the tissue. So that is the force from the body itself. And then if you look at the lower part, susceptibility and tolerance of the individual, meaning to say is that the individual mechanical properties of the tissue. The tissue can be the muscle, can be the subcutaneous fat tissue, can be our tendons, can be our skin. It depends on how far, what is the strength that the tissue able to accept this kind of a pressure or the force that was actually being exerted on it. And the individual geometry, morphologies of the tissue and bones, individual physiology and repair, and individual transport and thermal properties. I think this part here, this part of the risk factors is actually involved the overall of the body of the patients, including whether the patients are in a critically ill or the patients are actually bedridden, bedbound on any types of medications, or maybe the hypovolemic status, the status of the patients. They're talking about the perfusions and also the oxygen supply to the body itself. So that's how the whole tissue, whether is it able to be tolerant, which is actually been exert the force onto it, where the mechanical boundary conditions that come into play. So when these two come into play, and then it will talk about the internal strength and stresses or the damage threshold, where the tissue able to last. If it's unable to last, exceeded, the threshold itself, will it develop a pressure ulcers or pressure injury will happen. So this is actually very important that we talk about. However, by the time when we talk about the understandings about these pressure injury etiologies, how does it really form? A lot of people understand that it is because of the ischemic changes because of the pressure exert on the tissue, then the tissue will suffer from hypoperfusions, okay, less perfusions. Maybe suffer from hypoxia, then definitely the tissue will die as long as the duration is being sustained, prolonged, and the tissue is unable to recover as soon as possible, and then the tissue will die off. Eventually, it will lead to cell death, and more tissue is being died off. But again, people will think that if I do 2-hourly turning, okay, if I turn the position, offload the patient, will patient able to be prevent from this pressure injury? However, they notice that not everybody, not all the patients able to prevent despite patient admitted to the ICU or the moment the patient admitted in the A&E department and they start mobilizing the patient, yet the patient still develop a pressure injury. Then they're trying to understand how is it going to happen, even though I try to offload. Then on the far right-hand side, they think of like, could it be deformation? What deformation? It can be the cells deformation that causes of the problem itself. Now, here we'll be having a better understanding is that when the patient have an ischemic itself, then the problem is that impaired perfusion, then the reduced oxygen, definitely the metabolism will be changes, and then more acidic, and then that's why the cell will be died off. However, if the cells suffer from deformation itself, once the cells been deformed, of course, the cell membrane will be failure and the cell permeability will be increases, plus the disruption of the cytoskeleton. Then a lot of extravasation from the cytoplasm into the surrounding of the cells that will lose the homeostasis itself and eventually will lead to death. So it means to say that when this being distorted, the structures of the cells being distorted, I'm sure you can look at my cursor here on the right-hand side, right lower corner here. When the cytoskeleton integrity that able to hold the structures of the cells was being disrupted because of such a high pressures, okay, definitely the structures are being deformed and eventually will lead to a cell death. Okay, this slide from this part onwards here is actually a courtesy by Professor Amit Giffen, because I got the chances and I have the opportunity to present together with him, and then he actually kindness to share together with me for this site because he actually is a biomechanical engineer and he did a lot of study for the past 10 to 15 years to understand about the mechanism, the pathophysiologies of how the pressure injury being developed. Is it really just because of ischemic hypoxic damage, or is it because of other problems that was actually we are missing and then we haven't been discussed about it? So he actually talked about like cell deformations, and then he studied that definitely cell deformation, it would definitely happen. And then it was like quite numbers of a study because he's a biomechanical engineer. So he did an MRI study, a tissue engineering in the lab, and of course using the animal models that actually show that the pressure injury actually deform once the cells being deformed almost immediately. That causes of the pressure injury itself. And then from those days in the ancient time, when they're trying to punish the prisoners and then they're trying to grind and then trying to separate the body, they are able to do so, although we have a lot of elasticities and the muscle was there. Once the cells cytoskeleton was being disrupted, and then the cells integrity, cells membrane integrity will be compromising. Definitely, it will be dead. That's how what he understand or now come into play is that if we're talking about the conventional thinking, which is the ischemia part, it will take time to occur. Yes, because ischemia, it is not totally gangrene or no blood supply. It will just lead to reduced oxygens and then hypoperfusions or things like that. But it takes time for the cells to die off. However, if the cells being deformed, they are unable to maintain the integrity of the cell's membrane. So everything was just being deformed. The cell's membrane was being disrupted immediately within a few seconds to minutes. All right, then the whole thing is just being died off. So this may be able to explain why, despite we do 2-hourly turning or turning position for the patients, okay, and the patients still able to develop pressure injury. Now, how are we going to explain? If let's say we only have one bony prominence, especially our sacrum, we always think that, and we always believe that sacrum is the most vulnerable area to develop a pressure injury. Now, how are we going to explain that with that cells deform, but it leads to a bigger area in the surface that we are able to visualize and see a big chunk of it, like getting necrotic tissues, being died off. So because of, they are trying to understand, is it because of the edematous, because of the extravasation of cytoplasm, leakage to the cell surroundings and causes of the edema? So what does it do? Okay, what will happen to that when the surrounding tissues are actually edematous? Then they come up with these problems with the visual cycles of what is going on from this injury itself. You can look at my cycle here, my cursor, that when the pressure, especially the sacrum area, especially the patients were actually being bedbound, and then once the tissue or the cells being deformed, okay, underneath that, the moment it's being deformed, there will be extravasations of the cytoplasms or whatever, the fluid to the surrounding region that causes of the inflammation. And we understand that by inflammation, it will actually increase the permeabilities of the cell's membrane. So when you have an increase the permeability of the cell's membrane, there will be a lot of extravasations of fluid from the inner part of the cells to the surrounding tissue. We call the interstitial tissue, and that leads to the increase of the interstitial pressure. When this pressure in the interstitial tissues or the dirt space was actually increased, so the pressure will exert back into the cells or exert back to the capillary, whichever that they can try to push. They will actually compromise the cells, and the cells will die further because it will disrupt the cytoskeleton. At the same time, if you have a capillary at the surrounding region, so with the increase of the pressure, we also exert compressions on the capillary region. So that will actually double impact with more hypoxic damage and more ischemic damage around there. So this will continue with this vicious cycle, and this vicious cycle will never be break. There is a reason why when you have edematous, because of the inflammation, it will cause further damage into the surrounding tissue. So that's how Emmett Kevin come up with a graph and saying that if we can have usually conventional thinking by ischemic, it takes time. It takes time for the cells to die off. But if you have a deformation almost quite immediately. However, with the additions of the inflammatory response related to the damage, with these three add up together, almost like instantaneous, it's getting more and more damage to the surrounding tissue, and the tissue is getting bigger and bigger. So what is going on with this excessive interstitial fluid? It will actually to increase the diffusion distance, meaning to say is that the delivery of the oxygen into the tissue, it needs to travel a longer distance for the oxygen to be released, and also limit the diffusional removal of the metabolic byproduct and causes the compressions of the nerves, and the patients will be having pain. However, critically ill patients may not be having the problems because they have been sedated, or maybe they are heavily been sedated, so they may not be able to feel the pain. But however, it doesn't mean that they don't feel the pain, but there is no injury. The injury can be continuous over there. So the inflammation in the vicious cycle of the self-death biology in pressure ulcers and DFU. So what Emmett Giffen was trying to say is that by this vicious cycle, because of the inflammations and the pressure itself that causes more and more issue, it can be maybe able to deduce that maybe in diabetic foot ulcer, it also having the same problem, especially inflammation. Because diabetic, we all know that diabetes can lead to microvascular complication, especially for those of prolonged diabetic patients, that however lead to more damage because of the microvascular perfusion is being compromised, and the surrounding cells will be actually being affected, especially where the patients have a neuropathy as well, that will actually jeopardize the whole surrounding region, and the inflammation will set in, will actually double impact the whole injury. So in this chronic inflammation, especially, we understand that especially when there is an inflammation, our immune system, especially the innate immune system, is trying to control so that the inflammation, it won't be overwhelming. So on the left-hand side, you can see that innate immune system, the immune cells, you're trying to target those dying cells and trying to phagocyte and taking care of these cells itself, trying to reduce injury. However, in the chronic inflammations, especially in the elderly or the post-spinal cord injury patient itself, where they lost the direction because of the senescent cells and they're unable to detect the inflammatory, the cytokines, the chemokines, that's how the innate immune systems unable to have a unidirectional to phagocyte and to control the damaged cells. So with this, we can understand that inflammation as a critical juncture between the normal healing and chronicity. If we are unable to control the inflammations, okay, and of course, by reducing the pressure on top of it, offloading the patients by 2-hourly turning of it. However, if let's say we are unable to reduce the inflammations in that particular region, it will be a vicious cycle. In the end of the day, there will be more tissues being damaged, and then the injury, the surface area will be much more bigger. So what could be the solution itself in this part of it? I think in the international guidelines, they have been mentioning like 2-hourly turning positions, and then trying to get the nutrition back, trying to optimize the patient, especially in critically illness, whether you would like to put on a mat mattresses or static or alternating mat mattresses, or maybe some multi-layer soft silicone dressing that are able to prevent the pressure injury because it can help you to offloading itself. However, what about the anti-inflammatory parts itself? And then you can see that I'm highlighting, talking about whether it is pharmacology or non-pharmacology. At this moment, I don't think there are any studies that talk about whether pharmacological studies that helps in terms of anti-inflammatory, although we know non-steroidal anti-inflammatory drugs is one of the anti-inflammatory, medications, which is a types of pharmacological that will help. But at this moment, I don't think there are any good evidence to suggest that the pharmacological parts able to do so. What about non-pharmacologicals, whether they do have anti-inflammations in terms of addressing things like that? Well, there could be, but however, I think at this moment, study is very scarce, and then the level of evidence at this moment are not very strong. Maybe more and more pharmaceutical people, or maybe the companies, would like to play a role. If let's say they have an ingredient that talk about the anti-inflammatory, we like to see whether they can able to prevent. Because if we can break the vicious cycles of the inflammations, maybe we are able to help more patients, especially during this pandemic. We encounter a lot of COVID patients, especially category 5, admitted to the critical illness, especially they are on inotropic support, and also they are on ventilation, and then they are bedridden as well. And because of the COVID, what we understand is that the cytokine storm that will actually, building up into our body. So meaning to say that this group of patients, they will be actually full of these inflammatory markers in the body itself. It's not only just COVID, but if you look around our clinical parts, could be like pneumonia patients who are bedridden, and then some of the sepsis patients due to perforated bowels or the bowels problem that causes of the septicemia, and then require a critical support, a critical resuscitation. And then this group of patients may be having a highly chances, or the risk is quite high in developing pressure injury itself. So other than offloading, would there be any anti-inflammations that we can actually talk about it? By understanding from the mechanical points of view, I think that will actually help us to have a better management as well. Of course, understanding pathophysiology is one thing. I think the other part is actually trying to use assessment tools and see who are the patients who are actually develop or easily develop pressure injury that will help us in terms of like easing us our workload. That is actually much more important. However, they are actually in this international guideline, there are a few of them being highlighted. I think 4 of them itself. So people will look into the reliability and the validity scoring and the interrectal and the intrarectal of it, because to see which part is actually that talks about it. No matter what, it is actually all these assessment tools are specifically for pressure injury. like I've said, the reliability of using assessment tool alone may not be able to achieve the objective in treating the ulcers like what we want. However, I think the most important thing, which also been highlighted in the guideline itself, the combinations of both the clinical judgment and the assessment tool may yield a better result. This is actually much more important. So I think by understanding the pathophysiologies and the mechanisms of it, and together with the combinations of the assessment tool, of course, to have a better understanding of all the tools design, then we can actually achieve much more better in help us to prevent and then to treat the patients who are going to have a pressure injury development. So I'm coming to the end of my presentation. In short, my summary is that it is very important for us to have a better understanding of the mechanisms of pressure injury. Until today, we know that ischemic is not the sole answer for it. And of course, cell deformation is part of it. But if let's say with all these three together with the inflammatory markers or the inflammations that occur, that develop in the focal point, will actually expedite, will enhance or will aggravate the whole injury itself. I think these are the things that we need to highlight during our assessment and then during our work. And of course, identifying the cause of pressure injury, like sepsis or maybe the spinal cord injuries, or what does the mechanism they do, and to develop further and making more risk and higher risk. And what about inotropic support? Because they are a potent vasopressor, especially at the peripheral vascular. So that may actually jeopardize the whole perfusions in that particular area. And then, of course, the appropriate treatment plans, either or to treat or to prevent or both. I think by understanding with all these three problems that add up together, and then may be able to help us to have a better understanding itself. So, all right. Without further ado, I think that's all for my presentation, and thank you very much.